The problem is patients come in and say, I'm dizzy. They mean well, but there aren't a lot of words that we have to describe what they mean by dizziness. And when a patient just says, I'm dizzy, it doesn't mean much to us. So the questionnaire is to give the patient a framework to help to describe their symptoms. So we're just passing out the one that we put together. This is based on some research I did with Joe Goebel, where we looked at the eventual outcome and what questions best predicted diagnostic conclusions, and we included a shortened version of that questionnaire here. So we're going to talk today about evaluating the VEMP, because it's new and everybody has questions, and how to do a pretty quick exam of the dizzy patient. There are a lot of dizzy patients out there. I just updated this information. I got the Medicare data for 2014. 27% of Medicare recipients, which is pretty much all of our patients over 65, were seen for dizziness as a medical evaluation. So that's a quarter of the adult population is seeking medical care for dizziness. There are a lot of these patients. If you just say to the whole population, have you had dizziness more than 2 weeks? 16% will say yes. So it's common. 34% of patients, they did a study where they went door to door, randomized, carefully selected folks, and had them try and balance on a 2-inch foam and close their eyes. Over the age of 40, 1/3 of the patients fell over, meaning they're not using their vestibular system adequately to control their postural sway. Now, they can also have orthopedic issues, but this points to a huge issue, public health issue, because these people are at 8 to 13-fold increased risk of falls. Falls are a big deal. Medically, sociology-wise, our public health system, investment, expense, etc. So the Centers of Disease Control has placed fall risk prevention as one of its top priorities. Of the folks in this room, probably over age 65, when you get there, 1 out of 3 will have a serious fall each year. It's a lot of people. So when we talk to patients about dizziness, we want to know, is the room actually spinning? And I use the description of when you're a little kid and you spin and spin and spin and you stop and things keep going. They move in front of your eyes. You think that's fun when you're a kid. Not so much fun now. Do things actually move? And what I'm looking for is vertigo. Sometimes it's easy and they tell you, oh yeah, I lay back, things move for a minute. I get up, things move for a minute. It's been doing that for a few days. So you got benign positional vertigo. But to get from I've been dizzy for 2 weeks to when I lay down, things actually move for a minute is a step for patients. They're going to come in saying, I've been dizzy for 2 weeks. Well, what does that mean? So you really have to get specific, describe what you mean by vertigo. Patients use that word without understanding it. Then they can also tell you, I'm just off balance if I'm up and walking. That could be neuropathy or bilateral vestibular loss, but it just happens if they're up and walking. So again, you're trying to ask questions that will allow you to put them into categories where you can start to think of what might be going on. The thunderclap dizziness, I was minding my own business, all of a sudden things started spinning like crazy. I haven't been able to really work or get out much for a week. And by the way, my ear feels funny, vestibular neuritis. So you have kind of these scenarios that you're trying to figure out where to put the patients. So you want to know what it's like specifically. Don't use they come to the dizzy clinic, we tell them you can't use the word dizziness. We all don't understand together what it means yet. So we have to describe in detail what it is they're experiencing. How often does it happen? How long does it last? Really important question. Benign positional vertigo, a minute. Vestibular neuritis, days to weeks. Meniere's, 20 minutes to 12 hours. So it helps you to know how long the vertigo lasts. Is there a hearing loss? Is there tinnitus? And is it brought on by noise, pressure, or position change? And these are all questions that are highlighted in the questionnaire that I gave you. And then basically you want to look in the ears to make sure that there's not some kind of a erosive process, a cholesteatoma, that you can see the eardrum, which can be a real challenge occasionally, and check the hearing. Probably that's a really good place to start for any patient who's having dizziness. I've been surprised. Patients do not really tune in to one ear not hearing as well as you might think. Oh, I'm not sure if my right ear hearing is down a little bit. And I get the audiogram and it's a 70 decibel hearing loss. And we just missed that the first time through. So I really think a hearing test is a very appropriate thing to do as a first step. Now, there's a lot of popularity coming around for HINTS testing, head impulse nystagmus test of skew. This is being popularized in the neurology literature as an excellent way to screen patients who might be having strokes. Patient who presents with an acute vestibular syndrome, it's believed to be more sensitive than an early MRI in the detection of stroke. So there's a move toward including this in the emergency room evaluation. So head impulse nystagmus, we're kind of good with that. Test of skew, I think most otolaryngologists is a little bit of a reach, so I'll go over it in detail. The head impulse testing, you're asking them to look at your nose, and you move their head. I move it from lateral to midline, kind of fast, and make sure they can keep looking at your nose. If your left ear is weak and you move the head to the left, the eyes are going to go right past the target and have to jump back. And it's that jump back that you can see with your naked eye that makes the test abnormal. That means if you rotate left, you can't stay on target and you have to jump back, your left ear is weak. If you rotate to the right, you can't stay on target, go right past and have to jump back, your right ear is weak. So that's a head impulse test. Next is nystagmus. If we could click on this maybe to have it play, it usually just wants to play itself. But thank you. Great. So here's a patient. We're looking at them with video goggles. The patient's right ear is here. Their left ear is here, so they're looking at you. And this nystagmus is named, if we could have it play again, please, to the side of the fast phase. So it's beating to the right, I hope you can appreciate. We call this a right nystagmus, spontaneous nystagmus. If this is coming from an ear, if you ask the patient to fixate, so even if you don't have equipment, take a piece of paper, put it in front of the patient, eliminate visual fixation, look from the side, and you can see the eye jumping, and then you have them fixate, and it should decrease. So it's decreasing with fixation means it's coming from the ear and it's peripheral. That helps. So that's the nystagmus portion. So head impulse nystagmus. Now the test of skew is if you just have the patient looking straight ahead, you cover one eye, they're looking straight ahead, you cover the other eye, they're looking straight ahead, and their eyes stay steady. That's normal. If you cover one eye and they're looking at you, and you switch sides and their other eye was up there and has to come down, that's abnormal. And then you switch and this one has to come up, that one has to come down. So the eyes have a vertical excursion during skew testing. That's an indication of a brainstem infarct. They'll look they'll have nystagmus in one direction. They might have an abnormal head thrust test, but when they've got a skew with it, that means it's central. So head impulse nystagmus test of skew. Very good screening for stroke in the emergency department. And Frenzel's make everything a whole lot easier. There's our old-fashioned optical Frenzel's, which I think are around $500 now on Amazon. Somebody was asking me yesterday to find them a pair. But the new thing that's coming out that I really like are these super thin. They're called M glasses, and they're made by Strupp in Germany. They're on German Amazon. They're not on United States Amazon yet. They're $50. They're engineered so they're light and very, very thin, but they give you enough magnification that the patient can't fixate. You can look at their eyes in room light. They clip on the nose. They're very comfortable, actually. And I did a little head shake with them, and they didn't fall off. So they would be great just to put in your pocket, just like when you used to carry little eye charts around, and to be able to look at nystagmus and eliminate fixation. So hopefully those are going to be available in a few months in the United States. So head impulse testing, no special equipment is needed, but if you want, you can buy a certain head impulse testing setup that Halmagi made in Australia. Is probably the best one. It has to fit very, very closely on the eyes. It's almost painfully tight because it can't wiggle when you do the head impulse test. There's a little tiny camera, again, very close to the eye, because if you put a regular pair of goggles, the whole thing is going to be shifting and you won't get good data. And you can ask the computer to help you interpret head impulse testing, but you can also just do it yourself. Okay. And again, here is how to do the head impulse test, keeping the patient's eye on you, and the test of skew. So an acute vestibular syndrome means that one of the inner ears stopped working. Virus, surgery, injury, temporal bone fracture. And I tell patients it's like an airplane. You have two engines, you fly straight. One engine stops working, the airplane goes into a turn. The brain sees that difference between the two vestibular nuclei firing rates and thinks you're turning, and it sends your eyes to go catch up. So this is the basis of the nystagmus we see during acute vestibular syndrome, and it beats away from the affected ear. So you can expect after a labyrinthectomy that you're going to have nystagmus beating away from the affected ear, probably for about 3 days is the average length of time. And this can make some patients, not all, very, very nauseous and have difficulty keeping down fluids. But some patients don't feel it much, so it's really interesting. They'll have 80 degrees per second nystagmus. And, they're chowing down on a cheeseburger and they feel okay. So it's highly variable, the experience of what this feels like for patients. Postural instability is a concern if they're presenting with this from the community. Again, that's a predictor of central processes. So I used to tell my residents before we had HINTS testing, get them up and walk them around. And if they can't walk, they shouldn't walk out of the emergency room. So a very dizzy patient will hang on to your arm while they're walking, and they'll say, oh, I'm so dizzy. Oh my gosh, this is terrible. Oh, but their legs are working. A patient who's having an anterior cerebellar infarct, they try and take a step, and their cerebellum cannot control those long tracks, and they fall right over. So you can see movies of these folks when you try and get up and walk people having strokes. They just literally try and take a step and fall into the wall, which is different than the patient saying, oh, I'm so dizzy, but their legs work. So get people up and see if they can walk around to differentiate your central from your peripheral patient. Head CTs. So especially in the Midwest where I just came from, everybody who goes to the emergency room with dizziness gets a head CT. And if you go back the next day, you'll get another head CT. The most I ever saw in one patient was 5 head CTs. So basically head CT is worthless in the evaluation of dizziness. And a number of our national organizations are increasingly taking a stance about this. The American Academy of Emergency Medicine, the clinical value of head CT in isolated dizziness, vertigo, without the associated neurologic symptoms is very low. And of the 1% of patients that they found something on, if you had asked a careful question, they had focal neurologic symptoms. So as long as you check, is everything working? Can you feel everything? Can you walk? A head CT is not going to add anything. Head CTs pick up active hemorrhage. That's not the central problem that causes dizziness. That's a different problem. But it doesn't see posterior fossa very well because of the bone, and it only picks up active bleeding, which is not what causes acute central vertigo. So dispense with head CTs. They estimate $360 million in savings this year if we didn't do unnecessary head CTs in the emergency room. So it's a big deal. I think I've gone over stroke. So we do give prednisone to folks when we think they're having peripheral acute vestibular syndrome, milligram per kilogram per day. So an average adult, 60, 70 milligrams. I give it for 10 days. You can taper or not. I taper. Maybe it makes the patient slightly more comfortable at the other end. Avoid vestibular suppressants. You can certainly use them acutely to help people keep down fluids and to relieve symptoms for about 3 days. But then you really should advise the patient that continuing vestibular suppressants will delay their compensation, complicate their recovery, and is just not a good idea. Plus, Valium and its benzodiazepine friends are extremely habit-forming and tolerance-producing. So even if you take Valium a couple of times a day for a week, and then you try and stop, you're going to be shaky, dizzy, nauseous, and what you're experiencing is benzodiazepine withdrawal, not the underlying disease process. And so people just take more benzodiazepine. And, I've honestly seen people come in on 60, 70 milligrams of Valium a day, and then somebody put Klonopin on top of that. And, they really need 6 months of detox before we can treat their underlying vestibular condition, because it's so easy to get tolerant and habituate, and then they gradually increase the dose. So it's a very slippery slope. These are nice patients. They didn't really get the idea of, gee, I'm going to go find some benzodiazepines. They just got caught. So be very wary of prescribing long-term benzodiazepines for dizzy patients. Okay, benign positional vertigo, the most common thing. Even in my clinic, they've been to all over. They've seen a bunch of people. They still have to prove to me they don't have benign positional vertigo because so many of them do. And the story that you get is lying down, rolling over, looking up. The American Academy of Neurology and our academy just issued national guidelines for benign positional vertigo, which are very helpful. Do the maneuver. Only 30% of ENTs do the maneuver to diagnose BPPV. Isn't that amazing? You can put your ENT exam chair flat. You don't need special equipment. And just go, voomp, land back. They don't need radiologic imaging. Don't give them vestibular suppressants. Either try repositioning yourself or send them to somebody who can, like a vestibular physical therapist. Here in Swedish, I was so lucky when I arrived here in Seattle. Dr. Shumway Cook had been here. She was one of the leading physical therapists in the vestibular growth of the field. She trained a good 20 spectacular vestibular physical therapists. So I arrived in town thinking I'd have to build it, and it was already here. So at least in Seattle, we're extremely fortunate to have people all over the region who are really, really good at this stuff, and they all have the goggles, and it's really fun to work with them. So they're a wonderful resource for you to have treat patients. You could press go on this. I guess it's just not wanting to go by itself today. Thank you. So here's the little particle in the posterior canal. You lay back and it rolls. It pulls on the endolymph. This turns on the cupula of the posterior canal, and you get your characteristic nystagmus. So that's the pathophysiology of BPV. These otoliths usually live in the utricle, which is more in the center of the ear, but they flake off all the time. An enzyme usually dissolves them, but if you just happen to be unlucky enough to move your head quickly, it will go where it doesn't belong, and then the enzymes are not active in the canals. That's why they get stuck. If you just take 9% of people minding their own business, coming to see the doctor for blood pressure, asthma, yearly physical, Ogilvy did a wonderful study where he said, excuse me, can we just lay you back and see if you get dizzy? Almost 10% of people were positive for benign positional vertigo. Think about that. These are not patients complaining of dizziness. This is just your average patient coming in for some other reason. So what happens is people think this is part of normal aging. They just don't do that position, or I have to get up really slow. But we know that if they have benign positional vertigo, they have an 8 to 13-fold increase in their fall risk. Something goes crash and they go, whoop, or it's, family meal, holiday time, Thanksgiving, they're up on the chair, they're trying to get the platter, and it hits them, and they fall off the chair and break their hip. So it's what I talk to our primary care folks about within the whole Swedish network is every time an older patient comes in for just a simple physical recheck, anything, in a medical table, just say, oh, let's just check and make sure that your inner ears are okay, and just lay them back, one side, the other side. It will literally take a minute and a half. And really could make a difference for patients. So we're trying to get our primary care providers increasingly plugged in with this, and we actually are teaching them how to do Canalith repositioning. If they see something, they can't hurt the patient. All they have to do is turn the head over, and why not? And then potentially send them to physical therapy. Remember, we're dealing with hundreds of thousands of people with this, so they certainly all are not going to be able to come to see us. So we diagnose this with either Dix-Hallpike and or a lateral head turn. I'll show you why. And this is the info I give to GPs. You turn your head toward the examiner, you lay back, you don't have to super extend your neck at all. Even little old people can just be in neutral. And if it's there, you'll get upbeat torsional nystagmus. This is my nurse. She's got a great flexible neck, and this is as far back as I put people. So this is Dix-Hallpike. You don't need the goggles. I happen to use them because I see a lot of this, but that's the whole deal. And if they have a particle, it's a little delay, and then upbeat torsional nystagmus. Right posterior semicircular canal benign positional vertigo. After about 5 seconds, it'll slowly on its own go away. You've already got them down on the right. You think they have something. You just roll them to the good side till they're looking at the floor and sit them up. And that whole thing takes 45 seconds, a minute, quick. Hold on at the end. So here is me doing this maneuver. My nurse does not actually have BPV. I have to disclose. Nose toward the floor on the other side. This is billable. You don't need any special equipment. You do not need recording. It is CPT 95992. It's billable for primary care docs, billable for you. You can do it once in a day. Watch my left hand, just holding on to her shoulder. Very occasionally, as you put this particle back and it hits the utricle, they get a retropulsion. Woo! So just hang on at the end to make sure they're not going to do that. You don't want them to fall backwards. I do this in my office. I put my ENT exam chair flat, and I do all my repositioning in my ENT exam chair. So what you're doing is the particle's rolling around. This is right. Patient is turning to the other side. Particle's making the loop, and when they sit up, it plops right back into the utricle where it belongs. We tell them to sleep on their good side that night. We used to tell them to stay up, but that made unhappy people, especially if you tell them to stay up for 48 hours. That makes psychotic unhappy people. So now we just tell them to sleep on their good side, and the evidence looks like that is as effective as going through all kinds of other fancy post-procedure instructions. So here's the left eye with torsional nystagmus, just to show you its conjugate in both eyes. Here's the little OTOCONIA causing the problem. They are hexagonal crystals, they're calcium carbonate, they are the size of red blood cells. So we're always manufacturing new baby ones, and the big ones get kind of crumbly, and so it's a constant replacement and repair system with your utricular and saccular OTOCONIA. So they do flake off all the time. It's when the enzyme misses them and they go flying just by bad luck that you get the benign positional vertigo. It can also, about 15% of the time, go into the lateral canals. The nystagmus is different. It's more intense and it's horizontal. And this is why I suggest not just doing Dix-Hallpike and the new recommendations of the Academy. If they have a story, it's positional. Your Dix-Hallpikes are negative. Your next step should be just lay them back and turn their head side to side, and you may see horizontal nystagmus. In the interest of time, I'm going to go through the horizontal nystagmus pretty fast. You're welcome to come ask me later. So I'm just going to click ahead. It's in the lateral canal now, rolling around. It causes horizontal nystagmus. The treatment is this roll maneuver toward the good side. Of course, identifying the good side can be tricky. But if you just roll them 360, that works pretty well. Or there's other maneuvers where they turn slower that the Italians have devised. And most of your physical therapists will know this. Sometimes it's closer to the cupula, your nystagmus is still horizontal. And sometimes you've done a posterior, and you lay them back just to recheck, and all of a sudden the nystagmus changes and it goes horizontal. And your particle flipped out of posterior and fell into the lateral canal. You've converted it to a different canal. Easy to fix. If you've got them down on the right, and all of a sudden their eyes start going, just roll their head left. Think of the horizontal canal. It's trying to fall in, and all you have to do is roll them, and it falls right out again. So if you see this, if you do check, and you take them down, and all of a sudden they get that stuff, just roll them to the other side. they're fixed. It's good. It confirms a mobile particle, and you don't have to do anything else. Don't do anything else. It's now you've got basically a potentially risky cue ball in there. Just tell them to hang out that day. They can go like that. They can go like that. They shouldn't go like that. They shouldn't go like that. And when they go to sleep, lay on their good side, and you're done. Don't chase it around. It'll just keep. Now you get confused. You get order effects, and it makes for a long day. So here's a patient who had posterior BPV. This is left, posterior BPV. It's going left torsional like that. And we treated him. Laid him back down to recheck. Okay, their torsion's gone. I'm happy. I say to myself, what's that? So now they've got a horizontal right beat. This is an apogeotropic, away from the ground, horizontal canal conversion. Just roll ahead, you get yourself out of it. Sometimes it goes into the other arm of the horizontal canal. Here's that first patient. When I showed you the nice right torsional, I laid him down to recheck, and I say, oh, what's that? This is 15 years ago. And I'm thinking, what is that? I thought too long, unfortunately. I didn't know just to turn the head. Here's a particle falling into the long arm of the lateral canal. Patient starts screaming, patient starts throwing up. Very long day. I learned all you have to do is just roll the head to the good side, and you can avoid sitting there thinking, oh, what is that? What should I do? And it's not the right response. Just go, whoop. Okay. Here's a fellow who ran the New York Marathon, laid down and got dizzy. This is downbeat. So the majority of downbeat nystagmus is central. It's very common in multiple sclerosis. But this person had just run the New York Marathon. Boom, 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 boom. So our idea here is that those particles possibly got into the anterior canal. Otherwise, I mean, how do particles get in the anterior canal if you're not hanging upside down? But running a marathon is a pretty good way to shake your little OTOCONIA loose. So we repositioned it and we fixed it. So I think he's an anterior canal, but I'm not a big believer. You know, the anterior superior canal, both names for the same thing, has that common cruce. It connects to the posterior. I think of the vertical canals kind of as being one big canal. So I don't really mind if the nystagmus is torsional upbeat, torsional downbeat. I kind of know I'm in a vertical canal, but this stuff is probably way anterior. He got better. Recurrence 15% per year. Once you've had it in 1 year, you're more likely to get it back. So we give patients an instruction sheet how to reposition yourself. They can go online. It really helps to know which ear. That's where they get into trouble. They don't know which side it is. So we even have an instruction sheet on how to identify the affected side. You know, start from sitting. Turn your head, lay back. If it doesn't work, sit back up and wait. Then try the other side. Because if you're already down there and you're just rolling around, you got all kinds of order effects and you can't localize. So teaching them to sit up between checking sides and waiting can be very helpful. And we can talk them through on the telephone, which side is it now, and have you tried this and that? And then if it doesn't work, we have our network of PTs and we say, go see, you know, whoever and wherever, and they'll give me a call and let me know what they see. Not so benign positional vertigo. Sometimes canal dehiscence looks like positional vertigo. They lay back and they get a little torsion and repositioning doesn't work. And so be aware that occasionally if you see positional nystagmus and it's not getting better, that patient could have something else. They could have an acoustic. They could have a bunch of stuff that you want to know about. It could be central. So people who don't get better from what looks like classic posterior. Or you've got your patient with a unilateral nystagmus. So that can be neuritis or Meniere's. Half the time the nystagmus goes toward the Meniere's ear. Half the time it goes away. You get really confused if you're trying to figure that one out. But in Meniere's, you're going to probably see horizontal nystagmus. But it's also seen in multiple sclerosis, stroke, tumors. So it's very non-localizing. If it doesn't go away, that patient needs imaging, basically. 50% of these patients that I looked at had underlying problems with their inner ear, so I wonder if it's some kind of neuritis that gives them persistent positional vertigo. I think I just have a minute or two left. These are patients who they couldn't reposition, and this was shared with me very nicely by Dr. Horry, that there actually can be stenoses in the canals. So the particles can somehow wiggle in there, but boy, they're tough to get out. So don't think of the semicircular canals as necessarily being perfect little hula hoops. They're twisty, they've got bends to them, and they can have portions that are very narrow, which can make repositioning a problem. You guys all know about Meniere's here. We are using intratympanic steroids still. Our overall success in decreasing frequency and severity of attacks is about 87%. So it's certainly worth trying before you go on to more destructive options. And that pretty much correlates with outcomes from a number of different locations. So intratympanic steroids certainly worth and we use dexamethasone 10 milligrams per mil now. I can't get the 20 per mil anymore. The supplier really isn't doing it much. So we went to standard little tiny bottles of 10 per mil, which are easy to get, much easier for you to access. Semicircular canal dehiscence, you guys all know about, so I'm not going to go into great detail. Sometimes you see dehiscence on both sides, and you wonder, which side is causing the symptoms? Which side should I operate on? So it's helpful to know that if you put loud tones into an ear, you're going to get a nystagmus that tells you which side is active. So if you put a loud tone into the right ear, and the right ear is causing the problem, the eyes are going to go burp. So the ipsilateral eye is going to up toward and go up and in toward, kind of like that, if you put noise in the right ear. If you put noise in the left ear, it's the other way. So you can put noise in this ear, nothing happens, put the noise in this ear, the eye goes up, and you can say, this is the more symptomatic ear. So it helps to figure out which ear to do first or which direction to take it if you're trying to decide. And they've got, a lot of people have bilateral, either severe thinning or dehiscence. We did a, here we go, OVEMP. You probably want to know a little bit about that. I talked about it yesterday. I apologize for being repetitive. This is a crossed response, so you put sound in the left ear, you record from the right eye. It takes about 10 minutes to do this. It's so fast. Patient just has to look up 20 degrees. And if you have an abnormal response, it's huge. You just have to run one tracing through. It's not thresholds. So it's so much faster and easier. My audiologist does this. We really like it. The initial data on sensitivity and specificity is better than CVEMP. So it's the same little box of equipment, same evoked response, but you're just not dealing with neck tension and maintaining it and running multiple thresholds like you have to do with CVEMP. And just be aware that other canals can be dehiscent. This is a posterior canal dehiscence. Abnormal VEMP, and I get a CT, and here's your posterior canal, but there's a little diverticulum off the jug that pretty much intersects with it and causes an abnormal VEMP. We also see enlarged vestibular aqueducts more when we do CTs for abnormal VEMPs with normal hearing, which is really interesting. We didn't, that's childhood, progressive hearing loss, but now we're realizing it's got variable expression, and you can have dizziness and a large vestibular aqueduct, an abnormal VEMP. And here's a picture of one of these patients with a large EVA, and this was a truck driver, and his complaint was when I change lanes and move my head fast, I get really dizzy. And he had 80 degrees per second nystagmus on rapidly turning his head to that direction. So he's fine here, he goes like that. Can imagine the CSF sort of pushing, by inertia, right into the utricular endolymphatic valve, and you get horizontal nystagmus. I didn't know how to fix that, but at least we understood it better, and we're thinking about what to do about these people. About 50% of adults with EVAs have dizziness. So that's an area for some exploration. We published that and presented it at Barron a couple of years ago. Migraine, very common. The neurologists now have criteria for vestibular migraine with the International Classification of Headache Disorders, version 3. So now the neurologists are increasingly on board that you don't need headache at the same time. You just need a history of migraine. Dizziness is not otherwise explained, and it's quite likely to be migrainous in origin, and they're more willing to try anti-migraine medications. Venlafaxine is great. That's one of my favorites. Topiramate is really good. There's a host of others. Those are probably the two that are class 1 evidence-based. And to some extent, try it and see if it helps. So you can find this on the International Classification of Headache Disorders website and data and information for neurology. Chronic dizziness, we tell you should really start with your primary care. No need for us to be evaluating diabetes, hypertension, etc. But if it's positional, we're talking to those primary cares a lot about checking for benign positional vertigo. So the pathway that we're encouraging is maybe try for the primary care docs to send to the vestibular physical therapist, because it's usually benign positional vertigo. And then we can do testing, including VEMP, and certainly send to ENT if there's a hearing loss, history of ear surgery. If it's more headachy, send to neurology, or if it's the patient actually losing consciousness, which is neither migraine nor an ear thing, probably cardiology is the best place to start. But again, this can be complicated and patients can bounce all over. If you're going to end up doing imaging, MRI with contrast is probably still the gold standard. The contrast does help a bit in finding those small acoustic tumors and in prioritizing, if you do find demyelination, what's the age and is it enhancing? So we still like the contrast in the brain. People get better from this. We can measure them getting better on vestibular testing. The probably least beneficial thing to do is to give them long-term vestibular suppressants. Vestibular rehab, you can check the Vestibular Disorders of America website, VEDA, vestibular.org. It lists all of the vestibular therapists who are certified in the country. So your aunt in Peoria can find a vestibular physical therapist on the website. In Swedish here in Seattle and the broader Seattle area, we have, again, about 20 physical therapists who are part of our interest group who do a wonderful job with patients. If you need any patient education materials, please let me know. We have all of these, what is dizziness, BPPV, Meniere's, neuritis, canal dehiscence, and vestibular rehabilitation. They are available on the Swedish websites, but they're a little hard to find. So please feel free to email me if you need them, judith.white@swedish.org, and I'd be happy to share those with you so you can use them for your patients. Any other questions?